you've articulated how we can improve in terms of becoming more patient-centered in our approach and maybe even ways that we can measure it. Gaps still persist, and one of the complaints that I've heard from patients is that it seems like people don't talk to each other. So how can we improve intra and intersite coordination of care and address those kinds of gaps? Because it seems that things like unnecessary admissions and readmissions and ER visits are sometimes the byproduct of people not really speaking to each other. And Bhuvana, I'll start with you. How can we improve these coordination gaps, and maybe how can we change reimbursement models to ensure that these gaps get filled?
So great question. This is something that I care about a lot. Our patient-centered medical home that we've put in place addresses just that. So we try to have shared decision-making to start with, making sure that the patient and the family are educated about their diagnosis, the treatment that they're on, and the potential side effects that they're going to expect or experience. And making sure that their symptoms are managed adequately. Something as simple as pain management. A lot of times, maybe they forget to write the prescription, or they are not able to fill the prescription and they end up in the emergency room. So we've tried to incentivize physician groups to do exactly that and have possibly a nurse navigator role in the practice. We've had a single point of contact in our at Cigna to try to reach out to that nurse navigator to facilitate that discussion. Try to give them a census report, a daily census report of patients of that particular practice admitted in the hospital, because a lot of times they may not be admitted to that particular hospital the physician is going to, and maybe get admitted somewhere else, and they may not be familiar with what's going on. So this way, we tried to have someone from the provider's office reach out to the patient and schedule an appointment, hopefully within a week or so they don't get readmitted to the hospital. So we've tried to put in a lot of these measures in place to try to address these gaps in care. We also have a robust oncology case management program where the case managers try to also outreach the physician's office and let them know that their patient's admitted, or if they need a pain medication or they're talking to the patient. They also try to work through, sometimes help them with approvals and so on and so forth. So we've tried to look at the patient as a whole and tried to assist where possible to break down those barriers as much as possible.
Yeah. And how have incentives aligned to help promote that kind of care coordination?
So we are, our model pays a care coordination fee to try to encourage these kinds of activities, because, and some practices who are actively engaged in this, the physician group is engaged. It's more of a team-based care, and the practices that have put in a team to do the whole, all of these activities have actually done better than practices that have not done those functions or put in a team in place.
Better in what way?
So they are able to engage the patient, educate them, so they've done, they're able to keep the patients out of the hospital as much as possible. We also try to encourage having a 24/7 access, making sure that maybe there's somebody else who's taking call, they have access to the EMR, so they're aware of what treatment the patient's getting, and they're able to address the side effects. They document that the patient called. I mean, these are things that we're asking them to do. So then the doctor, when they come in the next morning, they have a message waiting for them to let them know this is what happened. So trying to have after-hours care. If they have nausea and vomiting, try to get them in and hydrate them. So when they do things like that, it has, they seem like they're able to avoid unnecessary hospitalization.
Yeah. I think one of the common laments that I hear from oncologists in our network is they say, well, we tell them to do that. We even give them wristbands with our phone number on them, but they still don't call us, they still go to the ER. So it's a constant effort, and it doesn't mean that we're gonna fix everything overnight, but it means that we've got a system in place to try and capture those patients to prevent avoidable care. And for patients who do end up in the emergency room or in the hospital, we have a real-time admission, discharge, transfer, and ER data that lets the physician know that the patient's there. Many of the elements that you described, Bhuvana, are part of the CMMI oncology care model, where providers have to have 24/7 access to an EMR. I think that's the way we avoid some of the confusion that exists. But physicians have to access it, and patients have to call to make that work. But I think more than anything else, We really have to fundamentally understand and transform how cancer care is delivered today. It's becoming increasingly complex, and even those cancer patients, they still have their diabetes and their heart failure and their other comorbidities. So communication is critical, and yet our communication technologies, while they may be better today, are they any better used than they historically have been? So I think there are lots of opportunities, but all that requires time and energy and skill sets that most practices, at least community-based practices, don't have. So I think the notion of paying that care management fee, which is part and parcel of OCM, and we've been doing since 2012, I think it helps fund some of those things that are integral to transforming how cancer care is delivered, and yet we've never recognized before. A lot of cancer care is the social workers and financial planners and the pharmacists that aren't reimbursed today. So I think we need to fundamentally reshape the incentives that exist and the payments that exist to help practices redefine how they deliver care.